Yes, today I went for jogging because full marathon is coming up. So today was the day for a bit long run, 22 kilometers. So welcome and let's start. Let's start with, we are starting with respiratory system. Definitely we'll be having lecture on 15th August. Sure. Because flag hosting we do at very early morning at 7:30. So no worries for 10:30. Absolutely. Will be. Does running burns muscles? No way. Means what exactly you understand or you tell me about burning the muscles? Means there would be some soreness because what really happens is that when you run, if your muscles are trained, then it is fine. But otherwise, it uses whatever the carbs which are loaded into the body, right? Those carbs are utilized. Once those carbs are utilized, body goes into the state in which the lactic acid formation occurs. Lactic acid or lactate, right? So that lactate is something which accumulates. It takes some time before it goes away, but it gives soreness of the muscle or the pain. Right? So definitely it happens. That's the reason you must have seen that many times when people join the gym for first 3 days, right? They are extremely enthusiastic. Right? They are extremely enthusiastic, and then on the third day, they मतलब इतनी खराब हालत that they are unable to even stand up from the bed. What really happens is that there is a capacity. Beyond that, when you go, you'll be going for anaerobic metabolism. That is anaerobic, that is without oxygen. So in that case, not audible. Now it is audible to everyone, Abhishek, because only your comment has come. Otherwise, everyone would have commented. So just check it or kindly relog in. Things should be fine. So and plus I can even check it over here also. What I was talking about is USMLE will take it separately. Today we won't be touching because USMLE or when we talk about the PLAB or any of the other competitive international exams, it's not something which we finish in 2 minutes or 5 minutes. It takes time. And I am planning for one entire session that, and you'll be informed because right now it is just too early for that. But we'll definitely do that. One full session in which you'll be able to ask all the questions. In fact, the whole procedure would be such that right from the registration number to all the way where you WDOMS, you just take your FAMER number, how to find the FAMER number, where to enter it, what are the charges, registration, examination cost, what if someone reschedules the exam, that is pretty costly, you'll be surprised by the cost, right? You will, if it's paid, no, it's not paid. USMLE, it's not paid. I'll let you know. Just excuse me for just 30 seconds. I'll be right back. Right. So welcome back. We made you about. I think I lied to you. I think you asked about the PDFs, and I already sent you the link. In case if I missed it yesterday, I'll send it today. Right? I'll just check it today also. In case if I have not replied. Okay. So let's start with our today's topic, and that is we are starting with our respiratory system. Now, what would be our action plan? We'll be starting with some part of anatomy, not in the full detail of anatomy, right? Because our plan is for physiology. But whatever the anatomy which is needed, we'll be going for that, so that we know the basic layout. Then we'll be talking about the actual physiology of lungs. Now, parallelly, I'll keep on telling you about the history taking. Now, this history taking, as such, it is one of the prime subjects when we learn medicine. But I really want that once the general anatomy, as such, say, most of the topics of general physiology, they are complete. And because we are starting with the systemic thing, so history taking is something which is not like an overnight thing, right? एक दिन में और एक रात में सब no, it takes time, right? It is like when you listen to the patient, actual picture should come up in your mind that this is what is happening. So if you make that habit right from the beginning, you will be able to understand the patient very well. At the same time, when your understanding improves, your diagnosis improves. Right? So time to time, I'll keep on telling you about that. What if the patient is having, say, pneumothorax? Right? Don't worry about what pneumothorax is. We'll be talking about. We'll discuss. But this is just an example that if we are talking about pneumothorax, so then there would be a very typical pain. There would be a very typical symptom. Right? So at times, the best thing is, say, when the patient breathes, right? When he breathes, there is pain, right? So his breathing becomes shallow and shallow, right? So when you try to mimic that thing, you'll understand that, yes, this is what really happens. So when you see the patient, right, within seconds, you'll be able to understand that what it is. These are what are called as the spot diagnosis. Right? Spot diagnosis. As said, this spot diagnosis thing, it comes up in post-graduation. Spot diagnosis means without speaking anything, you just see and you diagnose that this is what it is. So it is a matter of habit, and it helps a lot in your real practice, right? So we'll be talking about this history technique. Most vital thing, that is the radiology of thorax. That is the simple, सीधा साधा X-ray chest. X-ray chest. This one should know very well, right? So what we'll be doing is, as we'll proceed into the respiratory system, whenever we'll be talking about any of the condition, no, not today, just listen to me first. As we'll be proceeding with the respiratory system, we'll take a small break, and on that day, we'll be talking about the basics, that is the foundation of radiology. This foundation of radiology, as such, it is taught in final MBBS. But why not early? Right? It is very simple. It is very logical. And then every day, I'll keep on showing you 3-4 X-ray chests. I've got collection of more than 40,000 X-ray chests. Not X-ray, 40,000 total X-rays of the entire body. Plus thousands of CT, MRI. So whenever we'll be talking about any of the condition, I'll keep on showing you those X-rays, the real X-rays. The only thing what I would have done is that there would be some patient's name, so I'll hide those, because that is ethically we have to do it, right? So we have to. Should we make the notes? No, not needed. I'll be writing everything. In case if you want to write anything extra, you can. But this PDF in any case would be shared. And when we'll be learning the X-rays, so I'll put all those X-rays into this PDF. Okay, and on that we'll mark. And this would be our strategy. That let's say we are watching one X-ray chest, right? It is over here. Right? So let's say these are the lungs, and this is the right? Heart and over here, this is the hilum. And we find that, okay, there is a hilar mass. So, right, on that X-ray, yes, we'll be marking it. But then on the other page, on the next page, same X-ray would be put and nothing would be marked on that. That would be for your practice. Right? So every time we'll be following this. So once you have understood this X-ray, right? So even for the practice in future, you just scroll down to that page, right, in which there would be only simple plain X-ray. Right? Nothing would be written. In case if it is like, say, patient is having, say, there is sputum, right, and patient is having, say, cough since, say, 3 months, and say pain in the left sternocostal region, right? So that way we'll just write some symptoms. So this will be like a case. Actually, this is nothing but preparation of any of your competitive exam, whether it is USMLE, whether it is next PLAB, any of the Australian exams, everything. Everywhere they do expect some things like that. That is when something which you cannot cram and something which you have to understand. So this would be our practice, and this practice would be for every system. Right? Say, for example, when we'll be talking about cardiology, then in cardiology we'll merge two things. One, the X-ray chest, because in cardiology, say if it is tetralogy of Fallot, then the heart would be like a boot shaped, right? Boot shape. So such heart, these will be the very typical X-rays, very classical real X-rays. So those X-rays, they will give you the understanding that it is like that memory picture, right? You see that, and when that thing really comes in front of you, instantly you'll be able to recollect that yes, this was seen, and you'll be able to diagnose it at a its importance you will understand when you'll be doing to finals and when you'll be really watching the patients or the real X-rays, right? So this would be like a practice, very comfortably, without any stress. When you learn these things, right, you'll be very fine. Plus, do remember that these things cannot be crammed. And that is the reason we'll be taking one session for the radiology basics. That is about how to see the X-ray. Unfortunately, it happens like that once medicos, it happened with us also. And once you are into final MBBS, straight away in the clinics, batao, what's the diagnosis? And then you feel like, kya dekhe? I mean, and then they say, dikhta nahi hai, matlab it is such a big mass, and you feel like, where is the mass? Where is it? And then when it is shown, see, this is a fracture, this is the mass, we feel like, arey, haan. But once you know the method, so it is like it is just 1, 2, 3, 4 step. That's what I'll teach you, and we'll be requiring one full session on that. So I'll let you know when we'll be here. Now today we are starting with very much basic, very much foundation. Okay, so this would be our strategy. All right. Start with. So in respiratory system, obviously it will be dealing with respiration. And when we say respiration, it's inspiration, right? Breathe in and breathe out. That is the expiration. This thing should go well so that oxygen goes in and carbon dioxide should come out and the life is good. This is normal. When you are under stress, when you are exercising, when you are running, when you need more oxygen. So that means this is normal. While this is exertional, right? When you are exerting, when you are doing some work. So that is where more oxygen is needed, right? More oxygen is needed and more CO2 is produced, so that is to be flushed out. So that means exertion is. So one which is normal, it is also called as the quiet breathing. The breathing which you are doing right now, you are not telling your brain, that brain has got, there is, say this is the midbrain, right? So over here, this is midbrain, the pons, the medulla, and in medulla there is the respiratory center. Right? It is respiratory center. It is this respiratory center which is controlling the breathing, and we don't have to really work anything for it. So for the quiet breathing, the inspiration, that is when you breathe in, that is where the energy is used. For the expiration, there is no energy used. It is fully automated, absolutely zero ATPs are used. No ATP, no energy. It is totally passive, right? It is 100% passive. This requires energy. But again, so here is the right lung. This pattern will be there even in all the X-rays. There would be like, so this is the place for the heart, right? And the right lung and the left lung. If you see it inward, if you see it something like this, that when it is like this, when it is like this, on X-ray chest, if you see it like this, now, there is nothing from behind. Gentlemen, there is nothing from behind now, because patient is standing, X-ray plate is kept, and the X-rays, they are passing. So there is nothing behind, there is nothing posterior, nothing. X-ray ulta hai. Right? Someone has put the X-ray ulta, because you can watch it from both the sides. No? So that X-ray, that is ulta. But how to know it? There is always a marker. There is always a marker. Where on corner, it would be written like L. L is for left. Right? L is for left. Bradycardia, brachycardia, no, there is nothing like it is bradycardia. Bradycardia means heart rate is slowed down. So this is a marker. You will always find a marker at the left or the right, L or R. So over here, when you find that yes, the marker is like this, ulta, that X-ray is ulta. So just make it straight. But if you find it that marker is over here, marker is correct, right? Someone has put the marker correct. So you might have to just check with the technician that it was taken properly. Dextrocardia. That's right. That's right. So sometimes the heart is on the opposite side. It happens. It is the abnormality of rotation. So that is called as the dextrocardia. Or when you find that, say, this is the stomach, right? This is the stomach, and in stomach there is gas, what is called as the gas bubble, and we'll see that thing on the X-ray also. But when we find that gas bubble is also on the opposite side, so then when you figure out like this means that all the organs, it is like a mirror image. All the organs are also on the opposite side. Right? So when we say that this is the liver which is on right side, in fact liver is on the left side. The stomach which is on the left side, that would be on the right side. Everything ulta. So that is called as the situs inversus. Situs inversus. Right? When all the organs are opposite to normal. Dextrocardia, heart on right side. Heart on right side. So these are the, and it's very logical, right? Just look at the mark. So that would be one of them. Now, coming back to this, that these are our lungs. So this would be the trachea, and that trachea will be dividing, right? Will be dividing, and it will be dividing further into all these bronchi, right? And finally, the last thing which we reaches, it is called as the alveoli. It is the alveoli where the oxygen carbon dioxide transfer occurs. We zoom this thing. This is the alveoli. This is a single layer of single layer. So because it is single layer, so that's why oxygen and carbon dioxide, they will be able to pass through it very easily. What's on the opposite side? Over here, this is the capillary. So that means over here, there is blood. There is blood. This blood is in large quantity. In it, it has got the carbon dioxide because this is the blood which has been carried from the body, right? Which is getting carried from the body. So this oxygen, because this carbon dioxide is under guessing the expression alveoli. That's what we are doing. This is alveoli. This is alveoli. So because carbon dioxide is in high concentration and carbon dioxide over here is in low concentration, so that's why this carbon dioxide will be diffusing into the alveoli. Got it? Right? And because we are breathing, so large amount of oxygen is present over here. So oxygen concentration, that is oxygen pressure, that is much higher as compared to what oxygen pressure is present into the blood. Because it never happens that body consumes all the oxygen. No, there is some amount of oxygen which always remains there. So that oxygen, it diffuses in. So this is by the process of simple diffusion. The process is called as the simple diffusion. Simple diffusion. Simply because of the pressure gradient going, it will be exchanged, right? And then this blood is constantly flowing, right? So this diffusion keeps on occurring. It is like everyone takes turn, right? And then oxygen carried blood that is taken further. And then the whole process goes that how it really goes from here. It would be forming the pulmonary veins. Those pulmonary veins, they will be going into the left atrium to left ventricle to aorta, and then it goes into the entire body. So that's how it. Sure. Very simple, right? So this is right side, this is left side. You can see that right side is in pure blood and left side is pure blood. When we say pure means this is having oxygen, right? And the left side, and the right side is having CO2 or the carbon dioxide. The whole system goes like that. From here, this is the aorta. Aorta takes the blood, divides, right? It divides arch of aorta. Then these are the branches which will be going up. There's common carotid artery dividing into internal carotid, external carotid, which will be taking the blood to all the way to the brain. And then there is subclavian artery, which will be taking blood all the way to the upper limbs. And then this arch of aorta then goes down in the form of abdominal aorta, and then abdominal aorta divides into the form of common iliac, and then common iliac dividing into external iliac, internal iliac, external iliac, continuous femoral, and all the way to be supplying to the lower limbs. The point is that aorta will be supplying to the entire body. The way this system is, after that, there is formation of veins, right? There is formation of veins. So tissues, they will be getting oxygen. How? That this femoral, then it will keep on dividing, and finally at the level of tissues, right, things will be in the form of capillaries. So it is that these capillaries where the oxygen carbon dioxide transfer will start, right? The tissues will be taking the oxygen and they will be giving the carbon dioxide, right? So this exchange which occurs at a tissue level. So tissues they have used. Now starts the return journey. All these capillaries, they keep on say merging with each other. So they keep on merging, and then finally the veins are formed, and then these veins from the lower body, they go into the form of inferior vena cava. Similarly, from the upper body, that is head and neck, right? From the head and neck and brain, right? It is the inferior vena cava. Superior vena cava. Right? Inferior vena cava is here, superior vena cava is here. Both of them, they will be landing into right atrium to passing this tricuspid valve and going on to the lungs. In the lungs, right, to be going out in the form of the pulmonary trunk, right, pulmonary trunk. And then In lungs, once again, it goes all the way, they divide, and they reach to the alveolar level. This is the level which we were talking about. And over here, right, they will be giving carbon dioxide and they will take the oxygen and then starts the return journey, right? So then all these vessels, they combine, and then they form what's called as the pulmonary vein. So pulmonary vein, this would be the artery, right? Remember, pulmonary trunk is the artery. Artery is what is coming out of the heart. It is artery. So this is the artery, but this is the only artery which will be having the carbon dioxide. And this is the vein which will be having the oxygen. And this pulmonary vein is from pulmonary, it is as such it's veins because it comes from both the sides, right side and the left side. And then from here, it will be going into the left atrium. Into the left atrium. They'll be opening into the left atrium. That is the oxygenated blood, that's right. And then passing via, this is the mitral valve, bicuspid valve, and then from the aorta, it keeps on moving, it keeps on circulating. So this is how the blood gets circulated. As such, there is gaseous exchange at two levels. One, at the tissue level, right? And second, into the alveoli. All these gases exchange there. And that's the whole system, keeps on working non-stop. Breathing, simply breathing is nothing but it is just supplying the oxygen to these alveoli and taking the carbon dioxide. Which part was which part is not clear, Akshay? End part? Okay. So till this lungs, it is okay. Till lungs, it was fine. Okay. Right? So this is pulmonary. That's what I'm doing. So pulmonary trunk. Okay. Making it still simple. This is aorta. Aorta will be having oxygen, right? Oxygenated blood. Gives to body. When we say body, upper neck, upper limb, lower limb, head, neck, everything, right? Whether it is going up into the form of carotid or it is going down in the femoral, whatever, but body uses oxygen and it gives CO2. So from this point onwards, the journey which is starting is having carbon dioxide. Right? So all of them, they will be landing into the right atrium. Right atrium into the form of vena cava. So from vena cava. Right? So it is superior vena cava, that means it is coming from the top, and the inferior vena cava, which is coming from the lower body. And from here, it goes into the right ventricle, and from here, this is a big trunk, right? Big trunk. That is what is called as the pulmonary trunk, correct? Pulmonary trunk. Pulmonary trunk means it is the artery, big artery. And from pulmonary trunk, here comes our lungs. So in lungs, again, the gaseous exchange, oxygen, carbon dioxide exchange occurs. And from where this oxygen has come? When we breathe, right? Trunk or pulmonary artery. It is called as pulmonary trunk, right? Its shape is like this, right? This is how it comes out. This is what is called as the pulmonary trunk, right? Pulmonary. Okay. And then on the right side, then we say right pulmonary artery, then left one here, right? And this right side then will be going to the, say, this is the lung, right? So this area, it is called as the hilum, this area. So it goes into this and then it divides, right? Same way on the opposite side, correct? So that's why this is called as the pulmonary trunk, pretty thick. And then it goes into the form of vena cava. Lungs, they enrich the blood with the carbon oxygen, and it goes into the left atrium to left ventricle, and done. The circulation keeps on going. So, very clear, right, Akshat? It is the body, the tissues, they will be exchanging the oxygen, carbon dioxide, and it is the lungs which will be doing the carbon dioxide and the oxygen exchange, gases exchange, that they will be occurring at these two levels, right? So, same thing was explained over here. Over here, we are going into slightly, and that is the process of simple diffusion. Simple diffusion means it is this alveolar membrane is very thin, right? When it is normal. Now, there would be some conditions in which this alveolar membrane will become thicker. Why it can be thick? Well, what if someone is having severe infection, and because of this, there is accumulation of fluid which has come over here. Now there is a fluid. So that means oxygen or carbon dioxide, they have to pass through that fluid and then they have to exchange. Things would be slowed down, right? While this blood cannot wait, chalo, once I get the oxygen, then I'll move. Blood is constantly moving, right? Blood is constantly moving, whether it is getting that oxygen or not. So in case if it is not getting, so it will be simply passing. So what happens? The resultant oxygen concentration, which should be building up into the body, that becomes decreased, right? So when it comes to tissues will say, "Lao oxygen," will say, "Lungs ne nahi diya, jitna diya utna lo," right? So tissues will start crying, right? Tissues will start crying. Tissues will say that we have. So it means that we have to produce. We need to live. We need to produce the energy. So we have got our own way. Oxygen nahi dena ho to mat do. And they will be switching to what is called as the anaerobic metabolism. Anaerobic. Right? There are two types of metabolism. One is the aerobic. Aerobic, that means in which there is oxygen. Anaerobic, that is without oxygen. That means there is no oxygen. So many of the products in the body which are produced because of the anaerobic metabolism, lactic acid was one of them. So this lactic acid, when it accumulates, because it is not a usual normal phenomenon, you don't get muscle pain every day. But let's say someday you have run more, so then there is pain. Right? But as you practice, your blood circulation improves. Your muscles will also be knowing that, okay, it is at this speed we need to metabolism. Your heart is knowing, your lungs are knowing. So that is what is called as the increase or the improvement of cardiovascular efficiency. What I said on the first day, that you all are doctors, right? So that's why you should be in the best state of your physical fitness, because you understand these things. When you understand anything and when you do it, so it will be much more effective as someone is doing without understanding. So this is the reason that why it is, and I don't know if you remember that formula. Anyone who is remembering that formula, that how we should be doing the exercise, right? Irrespective of whether you have worked out or not. If it was like 220 minus your age, take the 80% of it, whatever the number comes, sustain it for 20 minutes. If you do this, that will definitely elevate your cardiovascular efficiency. Right? I think someone asked other question also. I just I don't know. Asked about some fat loss question. It was that so many. Just in case if someone wants a fat loss, right? Fat loss. So then make this number 70%. It is simple as that. How to lose fat and belly fat. You have asked two questions. How to lose fat? This is the answer. Right? This is the answer. Simple as that. Fat loss. If you want to, then 220 minus your age. Let's say your age is 20. So 220, that becomes 270% is 140. Keep your heart rate somewhere at the level of 140. And then do the exercise for 20 minutes. It is the fat burning. Out of sheer enthusiasm, you just start pushing more and you take it to 160. So then 160 is the cardiovascular efficiency, right? It is the cardiovascular efficiency. When the cardiovascular efficiency So it is when your lungs will improve, your heart would improve, but it won't lead to fat loss. It won't lead to fat loss, right? In fat loss, there is a, because what happens is that at 80%, body will be telling that yes, you are in rush, right? You are working more. So it will say, forget about the fat loss part, right? Now let's focus on heart and lungs. That's what will happen, right? Won't be bad for heart if beats are increased, not at all. Heart is meant for the increased activity, right? That's why the mechanism is there. Right? It would be bad if you go overboard. If anyone's heart it goes beyond 200 and still they are running out of sheer enthusiasm, so that is a dangerous thing. Right? That should not be done. Many times, right? It happens like, right? And say very soon that Mumbai Marathon is about to be coming. It happens on the third Sunday of January, right? So in that, you'll be finding that there are some fantastic, and say out of sheer enthusiasm, a good girl is running and you feel like, chalo, main uske piche bhagta hu, right? You do that. And that Paddle Road Bridge, that is so steep, that is like a mountain. Right? It is so steep that heart rate starts shooting. And it happens like, right? People collapse. Heart attacks, they are so common. And that's why on the near that Paddle Road Bridge, whenever there is race, right, always 2-3 ambulances, they are always there. Because people, they don't understand at times that beyond certain level, it is danger for the heart. And that's the reason this age factor, matters a lot. Right? Yeah, true. In gym also many people collapse because see, when they go for the deadlift, right, when the weight is extremely high, so when they lift, so at that time, breathe stops. And the muscles, they are demanding so much of oxygen that they collapse. So that's why Josh is definitely good, but one should not be brainless. Right? Dimag se exercise karo. So when it comes to fat loss, I've seen in gym many times people, they say just want to lose fat and on the treadmill, पसीने से नहा रहे हैं and दौड़ रहे हैं कि weight कम नहीं हो रहा. I mean, it happened just before few days back only. I said, madam, आपका वजन कभी कम नहीं होगा. She got depressed. That trainer that he said, करे सर मैं Reebok certified. मैंने बोला दोस्त उनका मैडम की एज क्या होगी? सेठ के पता नहीं. उनका मैडम पूछना तो नहीं चाहिए. Should not ask this question to a female. She said नहीं सर बताइए. She said 30. I said 220 minus 30, that comes to 190. 190, the 70%, that is coming to just 130 to 135. Just put the hands over there. Her heart rate was going beyond 155. I said, you will never lose weight. Slow down. So he said, at the speed of 6, kya wajan kam hoga? Kya fat kam hoga? I said, this speed never matters. So as you are asking the question, is this the speed of 6 kilometers per hour? For someone, it is like a snail, kachue ki speed. And for someone, it would be like, Are baap, bahut zyada. Go as per your heart rate. Right? Heart ko kabhi underestimate mat kijiye aap. Diet definitely plays a role, but these are the concepts. These are the very basic things. So if you want to go for a fat loss, very precise. It is what's called as fat loss zone. And second thing is that so if your age is studied, so it would be 140. Calculate karo na dosto. 220 minus age. यहाँ पे तो लिखा है 220 minus age. 220 minus age. That is your age is 20. That comes to 200. 70% of 200 is 140. So keep your heart rate between 135 to 145 because you can't just keep it absolutely 140. But if you hit 135 and if you start going below it, increase the speed by 0.1, right? 200 ka 70%, right? And if it starts going beyond 145, so then decrease the speed slightly, but try to put it into this zone. Right? That's why it is plus or minus 5. Second, you can't lose the belly fat only. It is the overall decrease in the fat. Right? Regarding the dextrocardia, I read your question. Dextrocardia is that the heart is on the opposite side. When the heart is on the opposite side, when the heart is on the right side, it is called dextrocardia. When all the organs are ulta, right? Liver, instead of say this right side, liver is on the left side, stomach, which should be on the left side, it is on the right side, right? Everything reverse. So that is called as the situs inversus. Right? When we'll be watching those X-rays, etc., I'll show you all these cases. All these. Yeah, that is good. Including heart. Yes, including heart. Yeah, say it never ever happens that heart is correct and organs are. Heart, it starts always with the heart. Right? So heart and all the organs, they will be on the outside. Something can be done to reduce belly fat. Yes, there are things, but it could be a long reply. That's right. If you want to lose fat, 135. 135 too, because I'm considering all of you are almost of the same age, right? So I'm roughly, you might be 18, 19, but just consider round figure 20. So these were the calculations. Situs inversus is not that much common, but once you are in practice, you come across. Maybe till now, I must have seen more than 100 cases of situs. So I can show you several X-rays, and I can show you even the CT scan, MRI also. That is where things go interesting. That's okay. That's okay. So we come to this point that during quiet breathing, right, during the normal quiet breathing, we said that there is inspiration, which is requiring a very big muscle. That muscle is diaphragm. That muscle is diaphragm. Diaphragm means, say, if this is the diaphragm. So over here, that's the thorax, and over here, this is the abdomen, right? And in between, there is diaphragm. That's the diaphragm. During meditation, when they say sit and then breathe in, they say kaise breathe in, pet phulao. So when you breathe in, so that means it is pet phulao is what? When the abdomen goes out, the diaphragm goes in, so that lungs, they expand, they get the space so that more oxygen can go in, right? So that's how this diaphragm is the muscle for the quiet. Normally, when you are breathing, you'll find you just put your hand on the abdomen. That bar. Dextrocardia settles in patient. No, it has got nothing to do with abnormal behavior. It is just the abnormality of the rotation during the embryonic stage, right? So it has got nothing to do with the neural system. Brain is absolutely fine. Many times the patient might not be even knowing that they are having this dextrocardia or situs inversus. And for you also, once you are if you are into radiology, then it is the occasional finding. Patient might have come for sir chest mein pain hai or there is anything else, and the patient's age is maybe say 40 plus, and then when you take the X-ray, you figure out that okay, this is the case of dextrocardia. So then you just put the X-ray and you ask your first year residents, theek hai, kya dekh raha hai batao, because you have deliberately put the X-rays ulta, right? So in the X-ray, the heart would be seen as normal, but the marker is over here, and this marker would be like this. This. Right, so that is where. So, no, what's rude in that? This is like a practice. It's like a practice. There's nothing rude in that. Because what I am telling you is be ready for that. I'll also be showing you such X-rays. Right? So, if you say rude, yes, I'll be. Because once you are into the practice, then you understand the importance of all these things. Because kitna bura lage, you understand, you wrote it how rude they are, but in exam or in real practice, how bad would you feel that, right? All those they are watching the X-ray and some senior comes and ye gali de ke sale X-ray ko seedha rakha. And then they say, "Arey, yaar, pura diagnosis change." So it matters a lot. That's why I'm telling you the first principle of radiology. Very simple principle. Every day I'll tell you something. The first principle of radiology is watch all corners. My teachers, they used to teach me. So I used to keep a diary, and I said that these are the golden sentences. There are 40 golden sentences. Right? So this was the first sentence. Watch all corners, because see, people miss this thing, right? Must likha hua hai, right? The patient's name is, I mean, I'll not take any name, but let's say it is a female patient, right? Female patient का नाम लिखा हो पुणे में, but nahin, straight away, अरे what is, and you find that yes, these are the lungs, and then you say, yes sir, we see the opacities into the lung, this is definitely, there are metastases, and then the question is asked that what could be the reason of this metastasis, and then you find the patient must be smoker, there must be some primary, they say where is the primary, and then you feel bad, you know. But just if you see that, yeah, it is a female patient, that means female patient, there's a carcinoma breast is most common. The moment you see that, right, you know that, and you try to see the breast impression, and you'll find that there is only breast impression only on one side. Opposite side, there is no breast impression. That means patient was subjected to mastectomy. One side of the breast was removed because of the carcinoma, and this patient has come for the follow-up. And still the patient is not good because there are multiple metastases, multiple secondary deposits. Just the name gave you such a big clue, right? Over there, it is also written like sometimes F/say 52. That means this is a patient, female, 52 years of age, classical age, right? Very typical age. Arey yaar, why are you going back? Heart on right side, dextrocardia. What was the sentence? I didn't write any sentence. I'm not understanding what you are asking. Okay. So this is the sentence. Remember this sentence. Watch, whenever you watch any of the X-ray, right? Watch all corners, because when you watch all the corners, you'll not be missing the marker, right? So if it is written over here, L, that is the marker, and you'll also come to know whether the marker is ulta or seedha, right? Sometimes left, sometimes right, but you'll know, na? Because right would be if it is like this. So we'll not be feeling stupid in our mind that yaar ulta X-ray rakh ke kar rahe hain, itna bhi pata nahi chala. And if the marker is right, if the marker is correct, and then we see this thing, so then all we need to do is we have to just call the technician. ठीक से marker रखा था ना? Because what if while taking the X-ray, he has put the marker, right marker on the left side, and then he has taken this. Normally, experienced technicians, they never make such mistake. But still, when you are supposed to make some big diagnosis, you just call करके पक्का ना? So, right, they will confirm. So watch all corners, right? This is the first sentence.
So,
हाँ बोलो.
so this left and right, which will be written on X-ray, that will be according to our left and right, no?
Patient's left and right. Patient's left. My dear, always remember that whatever you see on radiology, it is with respect to the patient, not to us, right? So, because see, if we both are standing in front of each other, my right side would be your left side, no? Correct?
Yes.
Right? So it is like if on my right side, if I put a marker, so then your heart will go on the right side. So for no reason, you will become dextrocardic. Correct? So
Yes.
always with respect to the patient. This thing, I mean, this is a very good question, because especially when we'll be learning CT scan and MRI, so in CT scan and MRI, things are not like this. In CT scan and MRI, so this is anterior, this is posterior, right? Lungs would be seen like this, right? This would be the area of heart. This is how the lung, because it is like a cross section, as if someone has cut over here. I take a cut and then watching, right? Then the whole thing is. So here is the body, right? Here is the body and the cut, and it is the slice. That's why it is called as the cross-sectional anatomy, cross-sectional demonstration, right? So it is like a X-ray blade which has taken the section, right? And then you are watching. Now this section could be into, it can be horizontal, it can be vertical, it can be an oblique, right? All those sections they are possible. And then there is one thing what is called as the reconstruction of the image. So in reconstruction, you actually come across that, okay, there is some pathology. So you combine digitally all these sections, you pick up only this much material, and then you reconstruct so that only that pathological structure that comes on the screen, digitally created, and you can even rotate it and you can see that, okay, from where the bleeders are coming, etc. All those things. We'll learn everything, all these things. Right? Practically, I'll show you about how exactly. Yeah.
So, but now you told that sometimes that technicians also can do a mistake. So, how will we identify that it is wrong, left and right value?
Normally, it never happens. But let's say if you come across that over here, right? Here, someone has put the R. So this
Okay, this
becomes
is
a
our
mistake.
right.
So this is
Okay.
like it has to be left. But when you find it R over here, so now this is completely wrong. Because
Yeah.
R, right, properly, if it is seen over here, right? So then R is always on this side. R cannot be on opposite side. This is the side of left.
Yes.
So that is where you have to just tell the technician. Because I'll show you all these practically also. So
Yes, sir, understood.
technicians,
Thank you.
they do make mistake, but once you see the X-rays, right, the logically, because if it is the ulta X-ray, so then it will be mirror image like this. That means immediately you correct it. The moment you correct it, and you'll find that if R is going on the opposite side, so that means technician has made the mistake. Okay. So that was about cross section. Arey mere dost, cardiac notch, when the things are like this, when the heart is any of the pathological, will not be touching any of the pathology initially. First we learn what is normal. Then we'll talk about all these bronchoconstrictions, asthma, then emphysema, pleural effusions, where it occurs, how it will be looking like, what would be the patient history, how the patient would actually present to you. I'll give you even that understanding that when from the pharmacological point, because now you know the receptors. Once you know the receptors, so that would be very easy to teach you that whether you give salbutamol or darbutalin, what should be given, right? Things which are selective or which are not. So you'll know that when we'll be giving it, so yes, you will also be increasing the heart rate. So when you are going for bronchodilator, and if it is not selective bronchodilator, so then it will also be affecting the beta 1. Beta 1 is heart. When you are stimulating the sympathetic system, that means you will be going for bronchodilator, but at the same time, you'll be increasing the heart rate of the patient, right? So patient will be restless, right? Patient will feel, something is happening to me? Nothing is happening. Patient is fine, right? But when you check, yes, you'll find that heart rate has increased. Right? And when the heart rate has increased, the heart is pumping more. So obviously there will be some elevation into the blood pressure also. Right? So patient becomes restless because what he or she will feel is that मैं तो आराम से बैठा हूँ या बैठी हूँ, and then why it is happening? Right? So unnecessarily they will be complaining. So this is where you just reassure. If you tell them that थोड़ा ऐसे होगा, but don't worry, you'll be fine. And then patients, they cooperate. It happens. But you need to know first. But you should know that why it is happening. But instead of many times, if you see, they say, "Ghar chup baith jao," right? Hota hai. No, no, that patient, right? He or she will be having such deep dissatisfaction. So these are the things which should be taught. Right? Looking at our notes, if someone comments कि अभी ये सीखने की जरूरत नहीं है, तो please ignore any of those things. Right? Please ignore. Because I get some of the emails also. I don't know who is sending. I know all those emails, they were from the fictitious name. But one of the comment was like कि बच्चों पे इतना जुर्म क्यों करने का, इतनी सारी चीजें क्यों सिखाने. It is not needed. I haven't replied to that. Anyway, doesn't matter. So for the inspiration, we learned one muscle. How to avoid hypertension, we'll discuss that. Sure, we'll discuss that. Simple one thing, stress to be reduced. And stress is reduced only when you pre-plan everything. When you learn anything in advance, your stress will never be increased. And I came across a few very good emails when they said that they have completed their entire upper limb. I was very happy to hear that. Right? They said that we completed all the videos of upper limb and now can you provide the questions? Sure, right? Definitely, I'll be sending the questions to you so that you can practice further. So, such things, they are very encouraging. Because when I know that you are studying well, then you'll be equally rewarded. Okay, so inspiration, this was one, that is the diaphragm, right? Diaphragm, this is one muscle. And then there is one more muscle, that is what is called as the external intercostal muscles. Intercostal. Very simple name, intercostal. Costa means ribs. Right? So this is our vertebra, backside vertebra. So just it is like we are taking a cross section. Right? On the front, right, there is sternum. So this is the sternum. This is the vertebra. This is the sternum. And then the ribs from the posterior aspect, they will be coming and they will join the sternum. Right? So it happens like if you watch this. So 1, 2, 3, 4, 5, 6, 7. Ribs number 1 to 7, they are called as the true ribs. True ribs. So true ribs means what? True ribs means they are starting from vertebra and they are reaching to the sternum. So see, that's how they are making the thoracic cage, right? Up to 7. But we have got 12 pairs, right? We have got 12 pairs. So then rib number 8, rib number 9, rib number 10, they end on the number 7 only, right? No, they are not floating. They are the false ribs. Right? 8 to 10, they are called as the false ribs. And it is the rib number 11 and rib number 12, they are not attached on the anterior aspect, right? So they are, if you really draw them, they'll be like this, bus. They are not reaching anteriorly. At the same time, they are not even attaching to anyone. So that's why they are called as the floating ribs. Floating ribs. When you breathe in, right, and when the costal margin, if you try to trace, so it is this margin. It is this margin what you are tracing. Right? So in the chest, right, in the chest, when we draw it like this, so this is the margin. Right? So that margin is by rib number 7, rib number 8, rib number 9, rib number 10. So collectively, they are making that entire margin. Right? Okay. So coming back to this, we are talking about now the true ribs, right? Rib number 1, 2, 3, 4. So these ribs, that is how they are connected and they are really formed. Right? And one rib, the second rib, and in between, these are the muscles, and these muscles, they are called as the intercostal muscles. So muscles which are present between two ribs, they are called as the intercostal muscles. There are, so out of which the outermost is called as the external intercostal. Very easy. External. So it is for the inspiration. For the inspiration, we have got the external intercostal muscle, and the second one is the diaphragm. So that is for the quiet inspiration. That is the reason that there will be some movement of the abdomen, right? That diaphragm will be going up and down, and then the expansion of the chest, that is because of this external intercostal muscle. And when it is the expiration, nothing is to be done. Right? Nothing. For the quiet expiration, this entire movement is 100% passive. Now, no effort, no, absolutely no effort, total zero effort. So for that, how these things occur? First, we need to understand some movements. Right? How the movements. What is one another sentence? Lungs are super lazy, and chest is over enthusiastic. This means lungs, they would always love to collapse. Right? Collapse. And chest will always say, no, expand. They will always like to expand. So that's why you need to tell both of them, right? Control, Uday, control, welcome, right? You have to tell them, bus, right? Otherwise, lungs will always try to collapse. Bus, right? So they have to take, come back. So lungs will say, chest will say, just expand. So you have to tell them, right? It is because of some very natural, jokes apart, there are some very natural forces which will be taking care of this. This is the foundation of the entire pathology. Because when we say that lungs, they would like to collapse, that means there is some other pressure which is keeping the lungs inflated. The moment there is that force is gone, that lung will collapse. So when there was COVID, the second wave of COVID, my right lung got collapsed, right? It got collapsed. And so there are specific breathing exercises about how to take that thing back. So lungs and chest, they will be working like that. Now coming to, let's say this is the sternum. This is the sternum front. And over here, this is, right, from side, if I show you, this is the rib, right? I'm just showing you one side of the rib. But the arrangement of the rib is very specific. Because ribs, they have to do two functions. One is they have to increase the, this is sternum. They have to increase the transverse diameter and they have to increase the anteroposterior diameter. So this is anterior, this is posterior, and these are the two sides. Because if you can make the chest cavity bigger, then the lungs can really expand. Right? Because lungs, they are soft structure. So we need to expand the thoracic cage so that we give some space to the lungs to expand. Now that thing is this. This is sternum. The angle is always like this. Right? The ribs, the way we draw like this, no, it is not like that. It is at an angle. Right? So if this is the vertebra, this is another vertebra, this is another vertebra. So the ribs, they will be arranged like this. They are arranged like this. That's the sternum. They are at an angle. Now, when they are at an angle, for some reason, if you can just do this movement, right? This movement, see, right? So then, see what happens. Right? The movement. Watch the movement. Right? So consider my thumb. My thumb is vertebra, right? This entire finger, this is rib. This one is sternum, connected. And when this is the normal position. And with the help of muscles, if we lift this thing, right? So what happens? If we lift this thing, we are increasing anteroposterior diameter. Right? See how? Initially, if this is the vertebra, and then they are at an angle, and this is the sternum, right? And when it is lifted, so it will be this thing will become bigger, right? Because if we see from the side, then the side is like this, and now when it is lifted, it will be like this. Because technically, geometrically speaking, it is you are getting this much distance. But when it would be lifted, it will be like this. So see, the anteroposterior diameter has increased. You got this thing? This is what is called as the pump handle movement. Pump handle movement. That hand pump. Right? Yeah, in which movie? Right? That movie should say. Right? So that is what is called as the pump handle movement. So pump handle movement is doing that. Here is the sternum, right? Connected like this. That's the rib. Here is the vertebra. And when this is lifted, it would be increasing the anteroposterior diameter. And this is called as the pump handle movement. Classically, in pump handle, right? This is done. So then there is one fulcrum which is fixed, right? So same way over here, the vertebra is fixed, right? And the whole rib is lifting it. So that is the pump handle which increases AP diameter, AP length. You can also say AP length, or the anteroposterior. The distance measured from anterior to posterior. That is increased. This is one. The second part, the ribs, they are not attached like this. They are actually like this. Right? The ribs are like this. Right? So ribs, they have got capacity to move like this. And the best example, if this is the bucket, right? In the bucket, that handle, right? Uska handle kaise? That handle is like that. Think it like that. If you lift the handle, what happens, right? This is again the bucket. So that handle, it is lifted, so that handle comes up. Right? The movement of the handle from here to here, it is that circular movement. Right? Like this. So when the ribs, they are below, right? And when they come on the sides, so see the transverse diameter has increased. So when the ribs, they move like this, they increase the transverse diameter. So thus we understood two things. One, increase in AP diameter, that is by pump handle movement. And second, increase in transverse diameter. And that is by pocket handle. Movement. So I hope these movements, they are clear. another important point that for the quiet respiration, the diaphragm and the external intercostal muscles, So these intercostal muscles, how would they work? If we say that we have got, let's say we have got these two ribs, and in between the muscle is there. Right? So when this muscle contract, right, it will lift the rib. Right? It will, because if the muscles contract, so obviously it will be raising the ribs. So these are the external intercostal, the muscles which are present between all the ribs. So one end contracts and takes the second rib up. So this is the external. So this is for inspiration. Right? Expiration, you know that is passive. What about the forced one? When it is the forced inspiration or expiration. Forced inspiration. You do it and you will come to know that which muscles will be used. When you breathe in, right? See, as soon as you say breathing, forced breathing, that means the entire thoracic cage is lifted. Right? But who is lifting? Neck muscles. Right? If you go on one side, then the muscle which is already crossing, it is what is called as the sternocleidomastoid. Sterno is sternum. Sterno. Cleido means clavicle. Right? Cleido. And mastoid. Mastoid is a process which is a muscles. It's a scalene. Right? There are three muscles: scalenus anterior, scalenus medius, and scalenus posterior. These muscles, they are of tremendous importance. In case if you have started anatomy of upper limb, you'll find that the brachial plexus, right, that is axillary artery, right, or that subclavian artery when it comes, right, that is where this scalene muscles they are present in the neck, right. All these scalenes, they are slightly deeper. Sternocleidomastoid, that is superficial, the cross one, right. The muscle which goes like this, right? The neck muscle, the most prominent neck muscle which you see, that is sternocleidomastoid, and these scalene muscles, they are the anterior, medius, and the posterior. Their purpose is they lift the entire cage, so from both the sides. So that's how they really work. So these are for the forced inspiration. Right? They are for the forced inspiration. And when it comes to the forced expiration, try to do that by yourself. Breathe deep in, and you will find when you breathe out, put the hand on your abdomen and you'll find that those six packs, they are getting used. Six packs, they are what? Rectus abdominis. So actually everyone has got the six pack. So everyone has got the six pack. So six packs, they are what? In between, there are all those. It is the muscles which are divided into the sections, right? It's divided into all these sections. So when they say six pack, so this is the rectus abdominis. So 1, 2, 3, 4, 5, 6. Right? Sometimes few have got extra, so they say that they have got 8 packs. But these 6 packs, it is present in everyone. This is because of the muscle which is called as the rectus. Rectus means straight. Rectus means straight. Abdominis means this is the abdominal muscle. Muscle of abdomen. This muscle is so powerful that actually when it contracts, so it is for the forced expiration. Similarly, there are muscles called interior or internal intercostal. Internal intercostal. These are the muscles, and the rectus abdominis. These are for abdominis. These are the muscles for forced expiration. There would be some other muscles like pectoralis major. That comes when pectoralis major, pectoralis minor for the forced inspiration. Right? When you breathe deeply, right? So then for the expansion of the chest, pack major, pack minor, they play a small role. But these are the major muscles. The point over here is this, from the physiology aspect, this you will not forget. That increased AP diameter, that is the pump handle movement, and increased transverse diameter is this movement. That is the bucket handle. So now you know it very clearly that in case if this movement is restricted, so then person won't be able to breathe properly. Right? Makes sense. Makes sense. If these movements they are not occurring, if the ribs are not occurring, moving properly, if there is any pain, right, for the movement, so then person won't be breathing like, right, right, so they won't be able to. There would be shallow breathing. There would be shallow breathing. Bucket handle? Sure. See this, a balti layout, right? Bucket, right? And this is the handle. And then lift the handle from one side. See how is the movement. You know? So from side, if we watch from the side, so that handle would be like this, right? That would be like this, and it will be going like this, the handle. So that handle, that's the movement. So ribs, they are classically like this, and then they come up. So when they are like this, see, when they are like this, see, only small area which is open. When they become like this, a bigger area, right? The increase in transverse diameter. Right? So that's how, this is a constant movement which is going on. That's how the lungs they get. Because see, it is the same fixed space. Within that space, when the lungs they want to expand, the lungs are not that powerful. Even they just push the ribs also, right? No. So it is like thoracic cage. It has to make space so that lungs can inflate. Do ribs protrude out in fracture, right? Whenever there is fracture, so that broken piece of the rib, it can protrude out, and when the broken piece of rib comes out, so then that small piece which is inside, it can really penetrate into the lungs and it can lead to, say, pneumothorax or tension pneumothorax can be risky to the patient also. So it can happen. Any of the injury, especially when there is car crash, why they say that you should be wearing the seat belt. Because if the car is going at the speed of 60 and the brakes are applied, the pressure is mv square, half mv square. Your weight is 60 kilogram, then car is moving at 60, but the impact would be 3600, and the 3600 multiplied by 60. Imagine the pressure which is so high. That is the pressure, that is the impact. So even people say that the car was moving just at the speed of 40 or a fracture. Yeah, can occur. This is how it can be. Because the kinetic energy, that is so high. So yeah, ribs break, ribs protrude, so many things. So many. I'll show you the X-rays also of fractured ribs. Okay, so let's revise what we talked today. Because from next time onwards, I'll be considering that what we discussed today, that was a foundation. Will not be repeating. So we'll keep on progressing. So this would be our strategy for every system. Even if it is a minor question, no worries. Bucket movement. If you are at home, get a bucket. If you are at home, get a bucket. How simple it can be. Bucket. यार उसका just आंख बंद करो तो भी you'll be able to visualize ना. Handle. The ribs they are arranged like this. We'll revise everything. Ribs are arranged like this, and that's the movement. So all the ribs, if you see, they are arranged like this. Right? Say, this is the ribs, they will be arranged like this. So attachment is higher. Posterior attachment is higher. Anterior attachment is lower. Like this. Right? So they will be, yes, the lateral movement, exactly, the lateral movement. So when they go on side, obviously they are side to side. And the pump handle movement, it is the up movement. So ribs, they actually combine, right? This is how they work, right? The ribs are like this, so they go up, so they are like this, they go like this. So there is increase in side to side diameter. At the same time, they lift the anterior, right? They lift the anterior. Litman Classic 3. You are a rich man. It's superb. That stethoscope is superb. Especially the acoustics of it is. You'll be able to use it, right? When you have purchased Litman Classic 3, use it. Not many are that lucky to have Litman right from the first stage. It's pretty expensive. No, it is not compulsory for everyone to buy Litman. You don't buy it initially. You can have some good status are available. So let's revise this whole thing. Inspiration and expiration, right? Normal and quiet. Normal oxygen movements, the quiet expiration, oxygen transfer in a normal way. When there is exertional, also called as the forced inspiration or expiration, when the oxygen demand is more and the carbon dioxide is to be out, we find the respiratory center into the medulla oblongata. Well, respiratory center, this respiratory center is the most susceptible, right? Susceptible to hypoxia. That's why this center is to be saved. That is the prime concern. When we find that someone has got a heart attack, so then why we say that he has got only few minutes. Heart, we can start even by giving the extra voltage. But if the respiratory center is dead, then rest of the entire body, that will be fine. But this person would never recover. The is respiratory center has died. The moment you remove him from ventilator, 3 minutes and the game over. So quiet inspiration and a quiet expiration. So this is expiration, it is 100% passive. And we talked about the marker, we talked about some concepts of radiology. When the heart is on the right side, it is called as the dextrocardia. When the heart is on the opposite side. When all the organs are opposite side, it is like the mirror copy. And it's called as the situs inversus. We discussed about your cardiovascular efficiency, 220 minus age, whatever the number comes, that would be, in your case, it would be 200%, 160. So at the speed of 160, if you maintain your heart rate, 160 means 150 to 160. If you can maintain, right, then that would be very fine, right? Your cardiovascular efficiency would improve. In case if it is difficult for anyone, right? It happens like if it comes like, there was a question also. If it comes like 140, at 140, if you are breathing heavily, fine, practice at 140. Gradually, you will start increasing. This is what is called as the VO2 max. Someday we'll be talking about this thing also in more detail. This VO2 max is such thing that with practice, as you increase, even when you'll be of the age of 50, you'll be beating someone who is of the age of 20. During exercise only your heart rate should be this, not normal. Normally it has to be between 70 to 80. Better. Yeah. So this fat loss during exercise, right, 70%, that is 135 to 145. So that would be good. In alveoli, oxygen carbon dioxide transfer, that is because of the simple diffusion, because this is a single simple layer, and that's the diffusion what occurs at that point. This was the circulation, in circulation from the left atrium to left ventricle via mitral, out into the aorta, and in aorta it goes to brain and the body, and then the capillaries, they will be exchanging the gas, CO2, O2, and then veins are formed, which will be returning to right atrium in the form of inferior vena cava and the superior vena cava, and via tricuspid they will be going into the right ventricle, and from right ventricle it will be going out in the form of pulmonary trunk. Pulmonary trunk and the pulmonary artery, the difference is nothing. Pulmonary trunk is the main trunk, and main what is coming out of the right ventricle, and then it divides. That's the reason that pulmonary pressure is low as compared to the pressure in the aorta. When we'll be learning cardiology, we'll be discussing about the pressure differences. That why the pressure difference in the pulmonary is less, because the blood which is pumped from here, it has to be pushed just 6-7 inches, right, on both the sides. Done. When it comes to aorta, it has to push the blood all the way to the brain and all the way down to the lower limb, right? So much power is needed. So that's why the musculature of left ventricle will be much thicker as compared to the musculature of right. Similarly, the pressure, right? All these pressure gradients, pressure difference, they'll be very important when we'll be discussing certain diseases, especially congenital, the diseases which are occurring right from the birth. So that by looking at that, you'll be able to tell that what would really happen to this baby after a few months, right? Depending upon the condition. Okay. So here, the thorax and the abdomen in between, this is the diaphragm, and this was the sentence, what we say, watch all corners, right? Watch all corners, where you will watch the name, you'll be able to watch the age. There would be the date also written, so that we don't prove stupid and telling, Acha, this patient is having this is the follow-up X-ray, right? It was taken in 2022, the fresh X-rays just underneath, right? So that's why, watch the date, watch the marker, right? Watch the marker, where the X-ray has been taken, so there would be the indication of that location, and depending upon the density part right now I'm not telling. Right? When we'll see the X-ray, I'll let you know about the density, so that why this surrounding area is important, because it will be a good indicator of the density also, whether the exposure was correct or not. So we'll see that. But at least these basic logical few things, again, watch all corners, and that will be our carry home sentence. Inspiration, diaphragm, and the external interpost. The reason behind it is that the position or how the ribs they are arranged. So inspiration is these two muscles, expiration 100% passive. For the lungs, this is one other important thing. They always try to collapse, and in case of chest, it always tries to expand. Right? So there would be the balance of forces so that one can breathe normally. Two diameters are to be increased so that lung chest capacity increases, so that lungs they have got enough space to expand. And that's why for the enteroposterior, we have got the pump handle movement. In pump handle movement, one end is fixed, right? One end is fixed, and then it is this opposite side which is going up and down, right? Up and down. So like pump handle, so we just move this up, right? And then over here, that's from where the water used to come. This was the classical pump. So over here, one end is fixed. So in pump handle, one end is fixed and second side only moves. So that is the pump handle, and that is for the anteroposterior length. Pocket handle movement, because ribs, they are oriented, anterior end is lower, posterior end is upper, and plus they are arranged downwards. So when they come on the side, when it's a lateral movement like this, so there will increase in the side to side movement, and that is what's called as the pocket handle movement. For forced inspiration, this is required. For the forced inspiration, sternocleidomastoid, that's sternum cleido is clavicle. From here, the muscle goes. So there are two heads. One is the sternal head. Second is the cleido, is the clavicular head. It goes all the way back, and behind the ear, there is mastoid process. That is where it goes. So that is the oblique muscle. And that muscle, because this head is fixed, so from there it lifts, so it lifts the entire cage. Another muscle, group of muscle, that scalene group of muscles, and scalenus anterior, scalenus posterior. So they will be taking part for the forced inspiration. For forced expiration, when the air is to be pushed out, these are the internal intercostal, the rectus abdominis. Rectus abdominis is once again lift, so that the thoracic cage that becomes smaller. So it is smaller. So that is the rectus abdominis. That's it for today. Next time, from this point, we'll start. Inspiration, you just do the forced inspiration, keeping your hand on the abdomen and see what happens. Breathe in and then breathe out, right? Forceful, breathe out. You find, yes, abs are going in. And that is the rectus abdominis, right? Rectus abdominis. This muscle is that muscle, which is right straight, right? And that will be pushing. For USMLE lecture, yes, we'll set a date. I'll let you. We'll declare it well in advance. Solve all the advice. All right. So thanks a lot. Thank you so much. And see you soon. Okay. And I'm putting this file onto the shelf. Thank you.
Thank you, sir.
Thanks a lot.
Thank you.